Good evening. My name is Robert Ryan, and I'm a professor in the Department of Family and Community Medicine at the medical school, and I'm also the vice chairman of that department for research, and I also direct the community engagement core of the Clinical and Translational Science Center at the Health Sciences Center. I have some opening remarks here that were prepared for me by the provost office, so I have to sort of read and do this mic all at once. Welcome, and thank you for joining us here this evening for the University of New Mexico's inaugural Community Engaged Research Lecture and Award presentation. An award tonight serves as an opportunity for the UNM, University of New Mexico, to demonstrate the high value it places on community engagement, which involves academically relevant research by faculty that simultaneously meets the UNM mission and goals and community's mission and goals and priorities. This award recognizes exceptional scholarly work that embodies UNM's commitment to community engagement and work that deeply and thoroughly affects the relationship between the university and our communities. I am pleased to be introducing this year's honoree, Dr. Nina Wallerstein, professor in the public health program, also faculty member, professor in the Department of Family and Community Medicine, and director for the Center for Participatory Research at UNM's Health Sciences Center. As part of tonight's program, we have the opportunity to get a glimpse of Dr. Wallerstein's significant contributions and then present her with the university's highest honor, first highest honor for community engaged scholarship. It was my pleasure and my honor to nominate my colleague of 30 years, Dr. Nina Wallerstein, for this award. I'm sure she's going to tell you all about the work she's been doing. So what I'm going to do is tell you about all of the glowing things I've learned about her over the last 30 years and the reasons why I nominated her. Her work embodies community engagement, especially as it relates to innovative community interventions. For 30 years, she has dedicated herself to service and scholarship in the field of community engagement, which has benefited the diverse communities of New Mexico and UNM. About 30 years ago, we wrote a book on community-oriented primary care. 30 years ago. And Nina wrote the chapter on developing a community partnership. And since then, symbolically, she has been writing the textbook on community engagement ever since. She is one of the founders and top scholars in the world on community-based participatory research, commonly known as CBPR. As a matter of fact, she co-edited the textbook, CBPR for Health, From Processes to Outcomes, which is used as a textbook all over the nation. And now she's the first editor of the third edition. Absolutely.
It's not done yet.
I only have a few minutes.
No, the book isn't done yet.
Oh. But you're still first editor. I get a signed copy, right? I got a signed copy of the first two editions. She truly believes that when communities own the research, it's better for the community and for us at UNM. It will be more sustainable and it will do more good. She created the Center for Participatory Research at the Health Sciences Center and has taught countless students, faculty, and community members the techniques of community engagement and research. She is a consummate professional and scholar with multiple high-level National Institutes of Health grants as principal investigator, over 120 peer-reviewed publications. I should just retire now. And multiple books to her name. In her spare time in the 1990s, she led the development of the first Masters of Public Health graduate program in New Mexico and served as its founding director at UNM until 2007. Now she's going to be joining the faculty of the new College of Population Health. Finally, let me talk a little bit about the missions of the Health Sciences Center and UNM. The vision of the Health Sciences Center states, the University of New Mexico Health Sciences Center will work with community partners to help New Mexico make more progress in health and health equity than any other state by 2020. The mission at the University of New Mexico is to serve as the New Mexico's flagship institution for higher learning through excellence in teaching, research, patient care, and community service. Dr. Wallerstein's work in community engagement has emulated these missions and vision statements for the entire time she has served on UNM's faculty, long before these mission and vision statements were written. We look forward to her lecture on community-based participatory research, Walking the Walk for Health and Social Equity. But before I turn it over to her for her lecture, she would like for you to hear remarks from members of the Center for Participatory Research team members, Lorinda Ballone and Rebecca Ray. And please join me in welcome them to the stage, and thank you very much.
Good evening, everyone, and welcome. It sounds like a really friendly crowd, so I'm pleased to be here. Thank you, Rob, for that introduction. Basically, from the Academy, we wanted to do an introduction from the community. I am joined by a couple of our research partners, by my colleague. As mentioned, I'm Lorinda Ballone. I've worked with Nina for 16 years now. First as a student, and then as a mentee, and now as her colleague on an R01 study. We are in our second year of, just started our third year of a 5-year study. With that, we thought we would give time to our partners in this study. We have transitioned in the work we do. When you do community engagement or CBPR, community-based participatory research, you generally work with what we call an advisory group, advisory committee. But we've been in these communities for 16 years, and we have seen them grow and their capacity grow, and have moved to the term now of tribal research teams. We have 3 individual teams here, and within each team we have a community PI. We've also used that term now within our communities. So I'll let them, and we said be brief. We will try to be brief. We apologize, but we've got lots of years of experience. First, Harriet Wakil from Hamas. She's not the community PI, but she's been a long-standing member of the TRT. The community PI, Janice Tosa, has 2 little ones and couldn't make it tonight. And we've been working with Hamas for 16 years now.
Okay, good evening. What I would like to say to Nina is to thank you, Nina, for your vision, your commitment in this work. You've been doing this a long time, and we, members of the Hamas community, really want to thank you. Through this partnership, we have been empowered as individuals, as families, and as a community. You've just planted the seed of what is yet to come. We have been empowered. We're going to be doing a lot more work in this area, and because of you. Thank you so much, and you really deserve this. Congratulations.
Thank you, Harriet. And then we have Ardina Orozco from Mescalero Apache. They heard about the work we were doing in Hamas and Rama Navajo, and we have partnered with Mescalero now for 6 years.
Hello, everyone. I was trying to think about a lot of different things about what I was going to say to up here, and we were having this discussion actually on Monday about the research and what it means and things like that to our community. And one of the things that I told Nina is that it's very natural for the community-based research model to be in our community, in the Native communities, and for her to really have that deep understanding of it. It's such a blessing to have somebody of your level to be in our community and in our groups, to really know where we're coming from and the things that you really push for. It's really very, very enlightening. And like I said, our community's new to this process, but the things that we're learning and the seeds that you're leaving behind will continuously grow for many, many, many generations, not years, but generations, because of the families that attend all of our classes and the people that are a part of our programs. The generations that you have touched is, far and wide. So thank you again for everything that you've done from the past 30 years, which is really, really amazing to me. So thank you very much. Yeah.
I failed to mention Ardina is our community PI from Mescalero Apache, and then we have Benelda Coho Balone from the Rema Nevo community. She's also our community PI. We've worked out in Rema, like Hamus, I believe it's 3 research grants now. And she's newer to the team, but we've been out there for also 16 years.
Good evening. Nina, I wholeheartedly share a lot of the sentiments with Hamus and Mescalero. I learned so much from you, and being new to the CBPR research and learning about everything you've done within my community, it's just so inspiring. And from my perspective, we really do feel empowered. A lot of the work that I do with the families, you can see it. It's very transparent with what kind of outcome occurs with the families and especially the students. They're my heart, and your work is making it possible for them to be empowered and just move on and be successful. So thank you.
Thank you, Benelda. What I forgot is the rest of the teams. So I'm going to ask, we have also members from our Hamus team here. You want to stand? I'm going to introduce. And stay standing. You're our Hamus team. We have a team from Mescalero. And then Raymond Navajo. Raymond Navajo. So I'll let Rebecca introduce herself.
Good evening, everyone. My name is Rebecca Ray. I'm Hickory Apache, and I've been blessed to be able to work with Nina, Dr. Wallerstein, and Dr. Lorenda Balone for the past 10 years, and really growing professionally in such a warming and loving environment has been heartfelt and wonderful, and to work with such amazing communities. When I think of my growth in research and with working with Nina, I think about you bring such a high level of expertise, but what I've always loved is that you value the expertise that we bring as well, that you never lessen the expertise that we bring to the table. And I always felt that even as a graduate student, before I was hired as as staff, that I was always valued and my voice was heard. And that's one of the biggest things that I've always appreciated about working with you, is not acknowledging the expertise that we bring as individuals, that regardless of your high esteemed level of expertise and stuff, that our expertise and our scholarly and our community, the wisdom and knowledge that we bring from our communities is just as important as the level of stuff that happens in academia. And so that's one of the things I've always appreciated and valued in my learnings with working with you. So thank you. And I'm here to introduce Marita Jones, who is also been a longtime partner with the Healthy Native Communities Partnership, which is a nonprofit organization out of Shiprock, and we've been working with for close to 15 years as well, and have been leaders and trainers in community engagement, and we've learned a lot from them as well too. So
saya Marita Jones siya politik nation lulusan basis change at ang basis shado yang national thank you very much for having me here. I'm Marita Jones. I'm a Water Plant, one for Maples Plant. Originally from Monument Valley, Utah, but yet to work in Chicago with some really wonderful people, and also around the country with all of our Healthy Native Communities Fellowship teams, which is our leadership program. So Nina and Becca actually helped us with that. We started planning and thinking about it in 2003 and have been going strong ever since. So Lena has been leading what we call our learning team, which is what we call our evaluation team. And Becca has been instrumental in really working and connecting with the fellows that come from all over the country. We have over 350 fellows that represent multiple tribes from 20 states. So it's really amazing that we get to help communities remember who they are as Native people, and to uncover that wisdom that's already there, to identify the issues in their own communities, and to create solutions from the wisdom of our ancestors. So that's what we do, and we wouldn't be able to do that as well without Nina's help and Becca, and also one of our key partners with Indian Health Service, Dr. Chris Percy. We drove here from Shiprock today and trying to remember when we met Nina. So Chris met Nina in 1987 at an APHA conference. And I met her in 1990 when she came out to teach us Shogun. So thank you so much for all of your work, Nina, and for your inspiration and for keeping us on track again.
She wants to take a mic from a Navajo woman. Wow.
are you going to give it to her now?
Yeah. So what we also wanted to do is, you're honoring her in the academy. We also wanted to honor her the way we would honor in our own community. We have a card and a rug. So I know, you guys should have stayed up here. Okay. So in giving her this rug, I'd like to highlight that I think for a number of years she had to be like the weaver. The rug wasn't done in an hour. It wasn't done in a day. It wasn't done in a week. The rug took time, and the weaver didn't have instructions and didn't have a manual to pull out. She had it in her head, and she knew what she wanted, and she envisioned what hopefully would come out. So I think I see Nina as that weaver. She's pulled together over the number of years this rug, whatever we may call it, community engagement, CBPR, and has developed capacities and abilities within communities, so they've all now become weavers themselves and play that important role in their communities. So thank you for, again, letting us interrupt the the agenda today and being able to share from the community's perspective our work with Nina.
So I'm really deeply touched and deeply honored to be partners with these wonderful people. And actually in this room are incredible other partners that I've had, from people working in public health and health promotion and as activists, and students and fellow colleagues, and just everybody I see, I seem to have a connection to. So, and friends. Thank you for my friends for coming as well. And to get this award is extraordinarily a wonderful honor, but it's completely paradoxical. You cannot do community engagement alone. And so the award should go to all of our partners that we've worked with, and I just really am appreciative that I can call you partners and can learn as much from you as I think I can share in my learnings and my thinking with you all as well. So I wanted to, okay, now I have to do the official talk. I wanted to start with I wanted to frame this talk as my own journey as a CBPR researcher. And sure, I will provide some definitions and some core CBPR principles, and then talk about 2 research projects, the collaboration with my tribal partners and who have you begun to meet this today, and then a newer, well, yeah, it's a 10-year-old research project, but we just got a new R01 for another 5 years to work on exploring the science of CBPR. And when I say that, it has to do with the question of what is the added value of participation to the research process? How does it change the way knowledge is created? What is the added value to the university to conduct community engaged research, or CBPR? And what is the added value within the communities who are partners to this process? How is this kind of approach enough different to really change the outcomes that we're talking about? We're not focused on a single grant outcome to increase breast and cervical cancer screening, or to increase the uptake of medication compliance around diabetes, or to deal with youth substance abuse. We're talking about a much bigger sense of outcomes. And I'll get to talk about some of that today, I hope. And then I wanted to actually frame this whole talk on the lessons I hope that I've learned along the way and still learn. And you know, God damn it, when you think you have lessons and that you're established CBPR researcher, but they keep coming. And so you keep learning, and that's the wonderful part of lifelong learning, of course. So I wanted to start with where I'm from. I'm from Topeka, Kansas. I was born in a year before the Brown versus Board of Education of Topeka lawsuit, which the Mr. Oliver Brown, a teacher, Mr. Oliver Brown, a parent, filed a class action lawsuit with 12 other plaintiffs from Topeka, Kansas. It got up to the Supreme Court, which ruled unanimously. Can you imagine a ruling unanimous at this point in time? Ruled unanimously that segregated schools violated the Equal Protection Clause in the 14th Amendment of the US Constitution, which changed the law of the land and promoted basically health equity, or equity, to have an end to segregated schools in this country by law, not by actual practice at the time. And although health equity was not defined at that time in 1954, I took some of the core people who've written on health equity, Paula Braveman, Margaret Whitehead, and looked at what it means and its strategies exactly to counter systematic and unfair differences among people who suffer from discrimination and exclusion, from any kind of difference. That's our goal of CBPR, that's the goal of community engagement, is to address the inequities that people suffer from, whether from exclusion, discrimination, poverty, racism, discrimination for sexual orientation or gender identity issues, and we've seen that currently as well in the US. And these are based on principles of social justice. So my parents, who were came from immigrant grandparents who fled, on my mother's side, Russia in early 1900s from the pogroms, anti-Semitism at that time there. And my father's family, who fled from Germany in between the wars from the growing Nazism threat that was beginning to happen, were raised in New York City. And they were raised, and they became socialist Zionists, and part of it, that's where they met, in a socialist Zionist club in college. And, but they were raised in poverty. Both sides of my grandparents were poor, but the value of education was paramount. And the value of social justice and fairness for all peoples was paramount. And even though when they moved to Topeka, Kansas, which for other reasons we'll go in later if you want, it was a small town compared to New York City, but they kept their value base, and coming into the Brown versus Topeka lawsuit, I think was a really important grounding for them, that they could also have those values in Topeka, Kansas. And just one example, my mother, who really had no connection at all to Spanish, believed that it was important for her kids to learn, and she advocated and pushed and fought to the Board of Education in Topeka, Kansas, to have Spanish taught in our elementary schools, and won. So I was raised learning Spanish in my elementary school. She also sent me as a young child to several summers in a row to live with a Mexican family in La Capital in Mexico City, who were really close family friends of ours. So I had my Spanish solidified in Mexico City. So I came from a high academic, intellectual, achieving family. I could not become a PhD, so to speak. But I also came from a family that valued culture, that valued language, that valued bridging and crossing cultures. And so I really attribute that to my parents. My family moved in the 60s to San Francisco. Who wouldn't want to move to San Francisco in the 60s? I was in high school at the time, and I became part of the anti-war movement, the 1968 marches, I worked with farm worker organizing, worked in the women's movement, continued that through college. In college, I met someone who had worked with Paulo Freire. I was kind of really not sure what I wanted to do. I dropped out of college and worked for a while as an English as a second language teacher with the Paulo Freirean methodology, philosophy, understanding, a Brazilian educator who really started a whole liberatory education approach, a listening, dialogue, action approach. We use it in Healthy Native Community Partnership. All of this interactive popular education we use in our family circle, family listening programs. So Freire became a distant mentor of mine since I was 20. And I was also able to go visit the Highlander Center, who is another center in the South in Tennessee that really embodies the same commitment to social justice, to union organizing in the 30s, civil rights in the 50s, landfill, environmental degradation in the 70s, 80s, and now a very bilingual, multicultural center still doing popular education. And so there's Miles Horton, who was the founder of Highlander, and Paulo Freire together, and they created a dialogue book together. So Paulo Freire's ideas, if you haven't heard of him, grounded me from my 20s. And everything that I do, this kind of belief that in the people, it comes from, I think, an understanding from Freire. When I got to the academy, Bill Weiss hired me in 1983 at UNM School of Medicine. He was chair of the department at the time. I began to be involved with empowerment intervention research, the ASAP program, Adolescent Social Action Program, working with youth, working in tribal and Latino communities, families, interventions, women. I started to move kind of I've never known why, but I seem to have gotten funding for substance abuse prevention. But really, I believe that the work we do together is around healthy kids, healthy families. It's not around one risk factor. It's around creating the whole. And I have been fortunate also to work in this state with healthy communities in the 80s and 90s. What year am I? But also with the Pan American Health Organization, with doing participatory evaluation of healthy municipalities in Latin America, some empowerment training there that continues. And I began to codify it in my own mind, and I don't quite know where the genesis of this is, but the creation of the term community-based participatory research took the participatory research from Latin America, from Africa, Asia, that term, added community-based from public health, brought it together. People like Meredith Minkler, Barbara Israel, Jeannie Ng wrote about it even before I kind of got knowing about it. So I began to name what I did as CBPR. And CBPR working with tribal communities, with communities throughout New Mexico. And also then in the last 10 years, what I call really important is, to me, thinking about what is the science, what is the art, practice, and science of CBPR. So again, my one starting point that I just wanted to say again is Paulo Freire. He wrote early on, Pedagogia de Press, to be a good educator, he was not a researcher, but an educator, means above all to have faith in people, to believe in the possibility that they can create and change things. And that you cannot do this work without having faith that people can take self-determination and really make community change their own. So I'm going to do a little bit of kind of more researchy talk now. Just what is community engagement and community engaged research? What is CBPR? Community engaged and community engagement of research is now a term that's used much more broadly, largely because, well, many reasons, but you can see it's a broad term. Community engagement is the process of collaborating, working with groups of people who are affiliated. It doesn't give you much of a value base, but just that you're working together as a collaborative, which is very important. And there are many ways to work collaboratively. CBPR, on the other hand, has a much more defined ethical purpose to it. And again, I told you it came out of this participatory research tradition from the South, and the community-basedness of public health efforts is an approach to research that equitably involves all partners. Equitably involves all partners. That's how you do that is a major concern and question. Recognizes the unique strengths that each brings, and begins with a topic of importance to the community. That's not the typical way academics choose research. We choose research, we look at gaps in the literature, we look at our own passions, we look at our own interests, but to start from the perspective of research, I'm preaching to the choir here, I know, but research should begin with the topic of importance to the community, with the aim of combining knowledge and action for social change. So social change is embedded in here, and to eliminate health disparities. This comes from definition from the Kellogg Foundation. There's a set, thanks to my colleague Lisa Kakari-Stone, working in the Community Engagement Corps, we created this easy continuum to see. Many of us do research on communities. We choose target census populations. We just choose the demographics. Some of us do research that's in community settings, in hospitals, in clinics, in healthcare for the homeless, in schools, in jails, in homeless shelters. But if you ask the question, are you doing research with the community, then you begin to go to what CBPR is. It's not on, it's not in, it is with. That's a very different perspective. There's a set of principles, some classic principles from Barbara Israel and colleagues, recognizing the community as a unit of identity, that it's a co-learning process. We've talked about co-learning already in our discussion here. It involves long-term commitment, balancing research and action. And to be honest, I have learned so much by working with my colleagues from your tribal communities. I cannot tell you, because I think the gold standard of community research comes out of honoring these set of principles, where tribal systems have to be respected and honored. We are under government control and review and approval processes. We can't just say, I'm going to come work in your community. There are approval processes. And the third one is not common to universities, that tribally specific data shall not be published without prior consultation and approval, and that the data belongs to the tribe. Very different way of thinking about, we like to academics need to publish, we need our data. And it takes years maybe to build trust for that kind of publishing, but not every community, not every community of color, not every community that's that's facing poverty and all of those issues have the same governance structure, but ethically, how do you think about doing research in a way that can provide that kind of ownership to all communities, even if they don't have tribal governance over them? So that's an important element to think about. So lesson 2 for me, start with for who I am. Lesson 2 for me is it's all about relationships. This is our early starting date here. Okay, here's Harriet here. And where's Anita? Right there. I just have to say that some of this starting with relationships comes from what we call proxy trust. It's who knows who knows who. And the proxy trust that Harriet and I had together was that she knew my colleague Bonnie Duran because they were students at Berkeley together. It turned out there was another bit of proxy trust. Harriet had taken a class with my mother in the School of Social Welfare at UC Berkeley. So when I met Harriet, she said, "You're Nina Wallerstein, Judith Wallerstein connection." So that kind of connection enabled us to start working together. That doesn't always happen, but often you have gatekeepers that you might know, people who refer you. Those folks are proxy trust. But trust starts slowly, and trust you have to build slowly. And the one way to ensure that there's a possibility of trust is you have to show up in the community. You can't expect community partners to come in to UNM and expect trust to build. So as my colleague Dr. Balone mentioned, we've had a long-term commitment and history with these three tribes, different ways of starting. One of the first grants with the Jemez Pueblo was a Community Voices grant where we tried to look at what are the strengths here, what are the capacities here, what are the interviews that we can do with stakeholders all around the community to understand those capacities. We had another grant with two communities. One of them was Raymond Navajo, and with our colleague Kevin English from Aztec, the Tribal Epicenter, where we were asked to come in on a kind of to build some level of capacity. And then what it turned out through some assessment process of public health systems and lack of infrastructure, that when they, instead of saying, "We don't want you to survey us," they said, "We don't want all this piecemeal of everything that you're doing. You know, Head Start has a survey, Job Corps has a survey, the schools have a survey, the health department has a survey. If we're going to really learn about ourselves, let's create a comprehensive community survey where we could look at housing and law enforcement and Head Start and health and education, water, all together." So that started us. What came out of both of these processes were a lot of issues around elder-youth interactions. And the idea that they wanted to have stronger connections, and there was a fear of loss of culture, loss of language, and the elders wanted to be engaged in teaching, but there was no program or practice that was supporting that. So I would say these two projects, though I loved them, were really not CBPR. It was only when we were asked to come back and say, "Can you help us create an intervention together?" When we were asked, did we become CBPR. So they asked us, "Can we talk about creating a family intervention together?" And so we started working on this, and we found another curriculum working with colleagues from Nebraska and the Plains and working with other tribes, and we asked if we could adapt that curriculum. We ended up in 4 years here in some pilot funding to adapt the program called our Family Listening and Family Circle program, and we were able to pilot it with a few, I'll talk about it in a minute, a number set of families. By the time we had done almost 4 years, our Apache colleagues, partners, had heard about the program, and they came to us and said, "Can you bring the program down to Mescalero?" So Lorenda was PI of that grant, where she was able to say, "Yes, we can bring it to Mescalero," and so we'll do that. So we had these independent pilots, and then we had the opportunity to say, "Okay, we now have a program. How can we test the effectiveness?" With single tribes, there's small numbers. It's hard to have enough numbers to be able to have this statistical tests needed to be able to implement a program with enough numbers to test effectiveness, to have comparison kids. They all agreed, they hadn't worked together before, really. They all agreed to come in together and work together to be able to aggregate the data together, and also for us to give the data individually back to each tribe. So this is a really important step in translation science and bring in testing effectiveness and learning that, yes, we can create communities so that we can actually understand if this program is effective. Here's the program. It's called Family Listening in 2 communities. It's called Family Circle in Jemez. You see the artist's logo of creating tribal-specific curriculum. Each of these logos represents a set of values, a set of history, a set of stories. They're not just a picture. And it's a program for 4th and 5th graders, parents, and elders. It's a dinner-based program, 12, 14 sessions. They come We have a welcoming tribal history, not just one session, but twice, family, tribal way of life, tribal vision, and then we get into community challenges and some family communication sessions. So at the dinner, they have the dinner, then we've embedded the specific cultural stories, language, and values that each of the tribal research teams have wanted to put in their curriculum. Each of the tribal research teams have made their decisions. We have kept some evidence-based activities and strategies from the literature around bringing up healthy kids, around family communication, around anger management, around building social support. But at the same time, it is completely embedded in the choice that each tribal research team has made. So it is a tribal-specific curriculum, but we share enough evidence-based strategies, enough to convince the National Institute of Drug Abuse to give us money to test the effectiveness. We are right now being asked, I think, by 3 or 4 tribes for our curriculum. We have pilot data that this has been effective. I'm going to show just a few stories of our program. A few pictures of the program. Starts with family strengthening and fun, a lot of icebreakers, activities, discussion of why our family dinner is important. A community history session. They're working on old pictures, photographs. They're creating their own posters. They're showing this is a history. There are no pictures, photographs from the 1300s to 1500s. This is a picture of talking about the Mormons coming close to Raymond, Navajo, and the kind of impact that that's had. Looking at traditional practices of sheep dipping, looking at the kids here on the right, doing their own drawing of what traditional life was like, reconnecting to their history. Our hypothesis here as a group is that reconnecting to tradition, to culture, to language is protective. We talk as a group around community challenges and the visions that they care about, and each family and the families as a group choose a community action project. It's based in a kind of empowerment model where the families themselves are not just learning about their own issues, but they're thinking of how they can do a service project back to their community. Then they're presenting the vision. So the kids are presenting the vision that they've concocted. The adults are sharing their visions that they've drawn or they've thought about. So there's a mutual sharing of vision. And then community action projects. So in this community action project, the whole group worked, not individual families, but worked on cleaning the fitness trail. You can see them doing some of the cleanup. And then the kids decided when they were going to present at the end that they would dress in traditional dress. Didn't come from the program didn't ask them to do that. The kids decided to do that. So this is kind of the culmination is this community action project. We don't have our current data because we've just started the first and second year implementation, but from our pilots, we were able to see that anxiety of children was reduced, that depression scale was reduced, a lot of pride in culture and language as protective factors increasing. So we had sufficient pilot data for NIDA, National Institute of Drug Abuse, to say this is likely an effective drug abuse prevention program, and we want to promote culture, language, and tradition as protective factors. We want to reduce the risks of depression and anxiety, and that would lead to increased substance use. So we were very excited, and so we're right now writing an article together, all of us on our community action projects, and we're moving forward in still testing out the effectiveness of the program. So the second project, just to mention briefly, I can't go into it deeply, but as Marita said, we've been working together since 86, 90, and 15 years of launching the Healthy Native Community Fellowship. The whole frame of the fellowship is around the metaphor and the symbol of the pan-Indian symbol of the medicine wheel, with the wellness of individuals and communities in the middle, along the life cycle of child through youth, through adult, through elder. Different knowledge bases, cultural, traditional knowledge, social, emotional knowledge, physical health knowledge, and intellectual, political knowledge, and a Freudian listening dialogue action cycle. And it is as much interactive and community-driven because each of the teams, each of the fellow teams, choose their own projects to work on and get the support for them to do that. And to me, it's been a process of reinforcing that the traditional knowledge that comes with sharing across tribes, across culture, is also as important as deeply being embedded in your own community. So lesson 4, I mean, I keep learning it as you're about to see, but listening to community language and knowledge as important in this process as learning and knowing the academic knowledge of science. And just for an example, we used to use the term institutionalize. We used to say, how are we going to help institutionalize these programs in the community? That's, you know, we don't want to just have a grant that comes and then ends and then it's over and then we're gone. But we've been challenged by our tribal partners that the term institution reflects the institutions of boarding schools, the institutions of federal policies that have been assimilative and genocidal. The institution of research has had a lot of negativity in communities where academics and scholars have gone in, collected data, left. That's called helicopter research. Often you fly in. It's called drive-by research in urban settings. It's called mosquito research where you come in and bite. So this institution of research has, the name institution is not what we wanted to promote. And so we started now, I mean, when did we learn this, Lorenda? It was a while ago, but yeah, starting to use the term sustain. How can we sustain programs? That's where we talk about sustainability rather than institutionalize. This year, only a few months ago, we were doing a write-up of creating a cultural centeredness paper and working with some case studies I'm going to talk about in a minute, case studies around the nation. And one of our partners was the Center for Deaf Health at the University of Rochester. And we're talking about, we want to promote community voice. And community voice is the word. And they said, wait a minute. If you use the term voice, that's oppressive to us. Because what we're doing is trying to, instead of having the English language be the dominant language, we want to have American Sign Language be the dominant language for us in our community. So just using the term community voice recolonizes us, reoppresses us. Can you find another way to talk? We were just blithely going, oh, we want to promote community voice and community perspective and community thought. Secondly, I just want to say that recently I was actually visiting one of the tribes, and it was a closing circle of the tribe, and they have this yarn connectedness kind of closing circle, and everybody was sharing in deep emotional ways their learnings, the kids and the adults together, and it was all in another language. And so my researcher heart and head said, I want to collect that data. This is wonderful data about the impact of this program. Yet on the other heart and head, I said to myself, I will never know this, what is said, and I should not even know it. This is data and knowledge that is for the community's own healing, for the community's own sharing, and for the community's own construction of knowledge. And it will not be part of my reports to NIH, and it will not be part of what I write about, but it will serve to benefit the community. So I just found myself at this pulled apart because I'm a scientist and I wanted to know the impact of the program on these kids and family. And I was feeling the emotion and not able to have access to the knowledge. So the value of community knowledge is often outside our Western academic gaze, and that also is what community gaze research is all about. That how do communities honor their own capacity and their own knowledge, and what will heal and serve them is not necessarily what needs to be written in academic journals. So I think that there's a very important learning, and that was a couple weeks ago that I was reminded of that learning again. So now I want to talk for maybe the next 10 minutes about a new study. Well, it's actually an old study, but we are launching our third stage 3 here. But it's a study that's had this window since 2006 of beginning to develop a conceptual model and a way to test it out. So we had some pilot funding from the National Institute of Minority Health and Health Disparities around a model, and I'll show you the model. We then had 4 years of funding of Native American Research Centers for Health funding to validate the model and create measures of partnering practices and outcomes. Now, I just want to say that this is all the rage right now. There's a lot of people doing community engagement, and a lot of people want to know if they're doing it well. And a lot of people wanting to know, how do they measure partnering practices to know if that's, and how do you measure, what's the most important thing to measure about partnering? What's the most important thing to measure about practices, and how does that impact outcomes? There are definitely task forces working on this nationally as well. We are going to be in we're in stage 3 now, where we're developing measures and developing an intervention to actually help partnerships grow and strengthen their own partnering. So this is the model. Does it look complex? It's really very simple. All of my tribal partners have seen this model. All it says is that research takes place in a context, whether it's a political policy context, whether it's a socioeconomic or cultural context, what health issue are you dealing with? What's the level of collaboration, trust, mistrust? What's the capacity? In that context, if you're working in a partnership, you have relationships, you have structures, you have individual characteristics. If you're working in a partnership, it will change what you do. So the intervention changes. We could not in the university have written the family listening or family circle curriculum. It could only be written with our tribal partners. We brought material to it. We offered help to create it, but it was the partnership changed the creation of the intervention. If you're working in partnership, it changes the research design. It changes, is it appropriate? Is it a way to engage people? Which key informants are you going to sample? Is the research design even appropriate? We were out in translating our community profile into Navajo. It took a long time to do that out in Raymond, Navajo, and as soon as we got there, they said, you cannot use Likert scales. Likert scales are, strongly agree, disagree, strongly disagree. We said, what do you mean we can't use Likert scales? You always use Likert scales in research. And they said, no, you cannot. If it's in Navajo and you read the question and story, the answer is yes or no. So what do you think we had to do? Or what do you think we did? Did we listen to our biostatisticians or did we listen to the community? Yes, we listened to, our biostatisticians chose to listen to the community. How's that? So it changes the research design, and then it changes the outcomes. The outcomes can be much broader. So I just want to take you through some of it. We, in stage 2, were able to test this model and do internet surveys around the country of 300 partnerships from our measures from the model. We also were able to engage 7 partnerships, with the Center for Deaf Health being one of them, to be case studies. So as part of that, we came up with some initial scales of ways to measure partnering. We came up from initial scales of ways to measure outcomes, and we tested these scales and we looked at associations between them, and we found that there are what we're starting to call emerging best practices. We're not ready to call them best practices, we're not ready to call them just promising practices, but emerging best practices. So I'm just going to take you through some of them. So in the context area, we found, or we know, that community capacity matters for outcomes. And so whether the project has what it takes to work effectively, we know that trust matters as well, but needs commitment and participation to grow. As you'll see, we couldn't really learn a lot about context through a health survey, through an internet survey, so I'll talk about that in a minute. In partnerships, we learned that formal MOUs can matter. They help define how you're going to memorandums of agreement, how you're going to agree to work together. That can help and matter in terms of outcomes. We learned that if community and academic people are aligned on a value base, that helps the synergy and helps outcomes. We learned that what we're calling bridging social capital matters, that is where community partners can bridge across and have the capacity to work with academics, and it means that the academic team has the capacity to work with community partners, and I'll just say up front, I'm going to talk about it a little bit later, that I have found I'm a perfectly fine, wonderful human being, but I'm a white outsider to the communities that I work with, that it's very important to have Native scholar colleagues at the university working with me. It's important to look at multidisciplinary, multicultural, multiracial, multiethnic teams that can really bridge beyond just what I could do by myself. And I'm not have any, and I have a lot to offer. That is nothing about what I can offer, but that the team itself requires a certain set of competencies that maybe I don't have alone. The intervention design also, we talk about, is the intervention culturally centered? Can it provide the partnership synergy? And how much the community is involved in all steps of the research process, from data from framing the question, from identifying the question, from being involved in doing background search for literature, from being involved in thinking of the design, from being involved in framing the data collection, from participating in data collection. And what I found is most important is the thing that is mostly not done, is that the community members and partners are involved in data analysis and data interpretation, because they're the only ones who really can know how it can be most useful to them. And that is the hardest to do. I mean, people don't come with SPSS or status skills or statistical package skills per se, but they can interpret the data. They don't even come with the qualitative data analysis skills per se, but they can interpret the data and know how best it should be disseminated in the community, how best it should be translated, how best it can be used to change programs, practices, and policies, which is our goal in improving health equity. And finally, the outcomes, we're looking at sustainability as an outcome. We're looking at changed power relations between professors, academics, and community partners. We're looking at the growth of personal and agency capacity, the level of community transformation in services, policies, and practices, and the growth of university capacity to do community engagement. It's not just capacity at the community. We need to change academia. And then, of course, we all care about the health outcomes, regardless of what issue you're working with. So these are kind of a set of measures we've developed up to this point. We also were able to do qualitative case studies. I mentioned you can just see the range of case studies. I'm going to focus on the Bronx in a minute. The Bronx faith-based case study started with a CDC grant to do capacity development working with churches, got an NIH grant to do diabetes. On the side, did a really important campaign of what they call to challenge medical apartheid, which is that people in the Bronx who are poor didn't get access to specialty care through a secret shopper survey, which apparently was just done in today's paper. There was a secret shopper survey about, was it about healthcare? Yeah. So they did that same thing, but we kind of tried to go across the country doing a variety of populations, disease issues, healthy Native youth, faith, cardiovascular diabetes, chronic disease. And we learned a lot from each of the case studies. What we found was the best tool for understanding context was to ask them to talk about the history of their partnership. We said, what do we need to know about your community that will help us understand this community and this partnership? They did not start with the grants. They started with a couple decades before in the Bronx with what they called the burning of the Bronx. This is when there was arson in the Bronx. The landowners, absentee landowners, and they were not fixing the buildings. They were letting them burn. Who knows what else they were doing. But they were collecting insurance, money settlements, and not providing safe housing, not dealing with the lead paint, not dealing with the unsafe conditions in the housing. The pastors there were veterans of the Civil Rights Movement. And they then joined forces with the Urban Family Health Center around this time. But when they talked about their history, what mattered to them, this context of where their struggle started was the most important. So you can't learn that in an internet survey. You need the qualitative and the quantitative together. They talked about the growth of different grants. They talked about their fight for low-fat milk in the schools instead of whole milk, which the dairy industry fought, but they were successful at getting low-fat milk in the school nutrition and the school lunches. And they created a Fat, Fit, and Fabulous curriculum. They've done a lot. They filled buses from the churches to go up to Albany to talk about medical apartheid. So this was a very activist coalition, started from 7 churches, moved to 70 churches involved in the coalition, with all kinds of different levels of research funding, which has led us to talking about CBPR as a social justice movement. And Shannon Sanchez-Youngman has been able to present this at the American Public Health Association meeting. But looking at different kinds of justice that we're talking about, from increased participation of community members at the policy table to actual structural change and fair wages, and dealing, in this case, with a wage ordinance in Chinatown from a project where they were looking at health and safety conditions in the Chinatown restaurant workers, and they found that the worst problem was not the burns in the kitchens, or not the slipping in the floors. The worst problem was wage theft. That people were being asked to work and not getting that extra wages. And this CBPR project, funded by NIH, was able to establish the first wage theft ordinance in the country, municipal wage theft ordinance. So we're talking deep level of potential policy change if you're doing community-based research on community priorities, listening to the community, so that even though they had written that they were writing a grant for health and safety, they changed when they heard about that it was wage theft. That's the role of an academic, is to listen to what is gathered in the survey data. They interviewed 400 restaurant workers in Chinatown, San Francisco, and that's where they could begin to look at fair wages as a structural form of justice. We ended up through this process, I have maybe 5 more minutes here, we ended up through this process talking about who we send out to our case studies. Who's going to go collect the data? Do we send to our native case studies native researchers on our team? Do we send to our African American case studies an African American member of our team? And this goes back to the issue I was talking about. What is the bridging capacity of the investigator? Just because we may be asking the exact same question, if I ask a question to a black man who is trying to get a job in the Boot Hill of rural Missouri, I will not hear the same answer than if a black investigator asks the same question. So the gathering of data is not a neutral event. The gathering of data is dependent on this bridging capacity and on having what we call cultural humility. So my lesson here for us as a team, we've written on this. Michael Mohammed is our principal author of this article. We've written on this, the importance of reflexivity on identity, power, and privilege, is to recognize that our identities as researchers matter. It's not to be who I'm not. I am a white woman. I was raised in a privileged household. I had a lot of intellectual capital behind me, had a lot of support. But who I partner with matters, and who have become part of the team matters. So if I have privilege, which I have, how do I use it in a positive way? And if I have recognition through reflexivity about the issue of identity. So I just wanted to make that really important point. We have learned how can we transform power relations, and it matters. If you're asking what are the positions of power, often academics are the ones that can get the funding. So we can use our privilege to do that. That's great. But how do we transform it so we're co-equal in making decisions, and the processes of research matter? Where are the decisions being made at what key points? Not every decision is going to be shared. I can say that as a PI. Lorenda knows as a PI. We have to make financial decisions sometimes. Not every decision is made in terms of sampling, because we might have more academic knowledge. But who makes the decisions on the whole really matter, and who is writing matters. So academics, if they're writing alone, that is a very different article, very different process than trying to do it collaboratively. And again, who has access to knowledge, and acknowledging that there's different forms of knowledge. So my lesson 8 here, I don't know if I've been documenting each lesson along the way, though they had numbers along the way, is that ourselves we have to change. We have to look at the establishment of community engagement centers, which we now have in this university. We have several of them, actually, and they're important because they provide a focus. We have to look at our own policy and financial incentives. For faculty, it's critically important in terms of transformation of tenure and promotion guidelines that they support not just academic publications, but publications that have a purpose in public health impact, or health impact, or education impact, or planning impact, or whatever impact your field is, that they have an impact out there within communities. That our pilot grants pay for food and pay for travel. That they don't do that is beyond me. To expect us to be community engaged scholars, it's the most inappropriate university policy that I know of in terms of supporting faculty to get out into communities. For students, here. For students, we have need for good service learning and CBPR research practice sites. We need to think about research really based on community priorities, inequities, the suffering, and just thinking in Bernalillo County of the 30,000 people in this county that don't have Medicaid, immigrant, others who don't have the access to the health care that they need, and who are served by pathways or other services. But what is the research that would help us change our policies at the hospital, change our policies? What are the stories? These people who are not being able to get the specialty care they need because they don't want to burden their families with the medical debt afterwards. You know, they're not getting the cancer treatment. They're just not covered. We're not fully covering our population in this county. Or we have to look at the issues of mass incarceration and all the systems all along the way, the racial profiling, the imprisonment of men of color in the policies that have supported that for many years and decades. And we have to look, what is the research that would help? How could university be helpful to communities who are suffering? What do we need to know from the families who've suffered at the hands of police brutality? So these are real issues. We have to listen to those real issues. The real issues of the communities that I work with obviously relate to growing up without becoming substance abusers, without becoming subject to all of the assaults. There's a lot of assaults on poor communities. And these assaults are really important for us to take seriously as academics and to listen for what is critical to the communities we want to work with. And most important, I think, for this is to realize can't do it as academics. If we don't recognize the knowledge from the community, we're not going to get anywhere in solving health inequities. It's a collaborative. We have to collaborate with this knowledge if we want to change policies and practices. So we are on our third round of a grant here to create tools to strengthen partnerships. That's some of us around the table. And we have 3 aims, and we've just launched. We're reconvening a national think tank of academic and community experts. We're refining our measures, and we're getting the opportunity to translate them into Spanish. The model has already been translated into Spanish and Portuguese. It's being used in different countries. We're going to be doing internet surveys of 400 federally funded partnerships from a database of 2015. And then we get to conduct a randomized control trial comparing partnerships that we'll be bringing into Albuquerque, 40 of them, not 4 different sets of partnerships, of federally funded partnerships to provide them strength and training of tools they can use for how they want to evaluate their own partnering. What are the goals they have? If they feel that they're not aligned in values, how can they align? If they feel they don't have this synergy, how can we support what the partnerships want as compared to other partnerships having access to resources on the web? So my lessons, starting from who I am, all about relationships, long-term commitment, listening to community language and knowledge, mixed method studies, history and context matters, being reflexive, and universities having to change. I want to end with 2 quotes from a dear friend, Pia Moriarty from San Francisco. Deep learning involves the whole body, blood, and bone, not just a theoretical or cataloging of insightful facts and analyses. Deep learning moves the feet to walk in a new way, moves the eyes to see from the new perspective won by that walking, and moves the hands to fashion the tangible world into a new image envisioned by a new seeing. And finally, if you've come here to help me, you are wasting your time, but if you've come because your liberation is bound up with mine, let us begin. So a very well-circulated quote by Leela Watson, from Aboriginal from Australia. And I have much appreciation for this award. Just 2 thanks from Monica Kowal in the Office of Community Engaged Learning and Research Provost's Office. David Hansen in the Faculty Senate Research Policy Committee actually made the decisions on this award. Dr. Lopez from the Office of Vice President for Research has been the host of this award, and many other centers and colleagues. I don't know if Kiran Katira is here. She does a Community Engaged Center for Student Learning. Dr. Art Kaufman from the Office of Community Health. Robert Ryan talked about his center. There's a lot of centers and dedication to everybody in this room. Thank you. And special thanks to all of my partners and public health and health promotion folks and people within the Robert Wood Johnson Health Policy Center. The new College of Population Health hopefully has this goal of partnering, has this goal of and values of equity and social justice. So we are looking forward to working as new partners from that department. So I'm going to end here. Thank you very much. So there's not really time for questions. We can stay a little bit afterwards, but I'd like to welcome Dr. Arthur Kaufman from the Office of Community Health and Health Sciences, and then Dr. Gabriel Lopez will close out the evening.
Do I lift this thing? Is this thing?
I don't,
Oh, this thing here.
maybe.
Is this good? Can you hear me? So I just want to say just a few remarks. Chancellor Paul Roth, Dean Deborah Hellicher send their wishes, regards, and all of us at the Health Science Center are so proud of everything that Nina has done. And in my remarks, I just wanted to give some examples of her impact and the impact of community-based participatory research, how it's had an impact on the institution. It's really moved the institution from becoming very much of a kind of a supply side university. We do great things, wouldn't you like to have these? To a demand side. What the hell do you want? Oh my God, how do we respond to that? And as a public institution with a public trust, that's critical. And that's been very much moved by Nina and her group. The other is a growing recognition of the ineffectiveness of the healthcare system in improving the health in our country. It's really shocking for the amount of money we spend. People are making a lot of money, but it's not having a substantial impact. And if you look at the power of social determinants, which has a much, much greater impact on health, then the question is, how does all the downstream money we receive get reallocated upstream? And that's where there's a lot of work being done at this institution. And that's one of the values of Nina's approach and why we honor her so much for her work. For example, if you look at the research at the Health Science Center, the signature programs, cancer, child health, brain and behavior, and others, these are major NIH funding categories. But if you look at what the communities have told us, every single county has a comprehensive health planning council. Their priorities are teen pregnancy, drug addiction, violence. Those are the kinds of issues that are much closer to social determinants. We have to retool to address those in response. Finally, there is a growing movement within the university bridging this Lomas divide, which is so idiotic, where architecture and planning and the College of Education, Health Science Center, all of the College of Population Health are now working together to try to fashion a responsiveness to what communities actually need, where the resources for social determinants, which will be our common language, are here, but communities don't know about it. We are so siloed into our departments, our programs, our colleges, that we have to overcome that divide within our own institution to respond effectively and let communities know what do we have that they can tap into, and we have to build those resources for them. So I want to thank you very much. We're so honored by this award that you received. Thank you very much.
My name is Gabriel Lopez. I'm the Vice President for Research here at UNM main campus. I'd like to thank you all for attending tonight's lecture and for joining us in honoring and celebrating the achievements of Professor Wallerstein. I'd like to offer special thanks to the members of the UNM Faculty Senate's Research Policy Committee who kindly offered their time to select tonight's lecturer. I'd like to acknowledge also my predecessor, Professor Michael Dewar, and Dr. Monica Kowal, Associate Dean Monica Kowal, for helping to set up this inaugural lecture on community-based engagement and learning and research. It was really, I think, their brainchild, and this is a great start. Finally, I'd like to recognize the staff in my office, specifically Lauren Medrano and Sally Jameson, for their hard work in organizing tonight's event. Please give them a round of applause. Now I'd like to personally thank Professor Wallerstein for her efforts in the advancement of community-engaged research, and to invite her to accept this inaugural award in recognition for her extraordinary work and contributions to the University of New Mexico.
I mean, again, I just really appreciate all of you coming. I know many people in this room are completely dedicated and do your own fabulous work in this arena. So thank you all for your efforts. And I know it's not just, again, one person, but each of you who are here from the Academy has their own set of partners, and you know what it means to be working in the kind of time that it takes. So thank you, and really thank you so much, my partners, for coming. Our partners from the Center for Participatory Research. And there are other students and fellows and many colleagues in this room who are working together, so thank you all. Okay.